The liver is the most common site of metastases for colorectal cancer. And while a small percentage of those can be resected, the majority of them cannot, either due to the distribution or the bulk of disease. So, second line chemotherapy has been the mainstay of treatment for metastatic colorectal cancer, whether it's to the liver or other or elsewhere. And our goal in this study was to see if we add yttrium 90 radioembolization during that time of second line chemotherapy, whether or not we can prolong their progression free survival. Patients that met eligibility criteria were randomized 1-to-1 to standard chemotherapy according to the institution standard, or chemotherapy with yttrium 90 radioembolization added during their planned cycle 2 of chemotherapy. So the cycle 2 was held and they received Y90 in place of that. Main eligibility criteria were unresectable disease based on distribution of disease or other factors. A preserved liver function, so they had to have a bilirubin of less than the institution, 1.2 times the institution normal, an albumin of greater than 3, and no significant ascites. And these patients would then, once they met eligibility and they had no contraindication to getting intraarterial therapy, they were then randomized in a 1-to-1 fashion to standard chemotherapy or Y90 with chemotherapy. They would receive treatment and they were monitored at 8-week intervals for progression or until death. The primary endpoint was, there were 2 primary endpoints: progression-free survival or hepatic progression-free survival. And if either of those were met, based on the statistically significant difference that we predetermined, then it was felt to be a positive study. At the study conclusion, we found that both co-primary endpoints were met. The progression-free survival for patients that received yttrium 90 in addition to their standard second-line chemotherapy was 8 months compared to 7.2 months for those that received chemotherapy alone. And although this does not sound like a big difference, it did correlate with a hazard ratio of 0.69 and a p-value of 0.0013. So this is a statistically significant benefit over time for these patients that received Y90 with chemotherapy. In addition, the hepatic progression-free survival was also prolonged for those patients that received the Y90, with hepatic progression-free survival of hazard ratio of 0.59. And their absolute progression-free survival was 9.1 months compared to 7.2 months in the chemotherapy alone arm. So both of these endpoints were met, and both met statistical significance. We found that there were certain categories in which in which we can identify patients that could benefit from this therapy. We found that there was a benefit for those that had KRAS mutation, for those that had a left-sided primary tumor, for those that had a moderate amount of liver disease, so greater than 10%, less than 25%, and for those that received a biologic agent in addition to their second-line therapy. So during the second-line therapy option, patients got their institution standard, and not everybody had access to a biologic agent in their second line of therapy. And only about 40% of patients received a biologic agent during their second line. But we found that those who did demonstrated an even greater benefit with the addition of Y90 to their therapy. There are a number of predefined subsets that we're looking at as well. And some of those still need further evaluation, but we did find that there was no deterioration in quality of life during this time. We found that there was an improvement in disease control rate. Unfortunately, there was no change in the overall survival for patients in either arm. And this may be due to a number of things. This may be due to the fact that there were third line and subsequent lines of therapy available. Patients received some patients in the chemotherapy alone arm subsequently went on to receive an intraarterial therapy. And the difference, while it's not a large difference in median progression-free survival, there certainly is a benefit as evidenced by the hazard ratio. Um, and perhaps with a bigger study or better selection of patients, we may be able to identify those that could have a survival benefit. The EPOC study was designed for patients with liver-confined disease. So this therapy of yttrium-90 radioembolization could be beneficial for those patients with liver-confined disease. Using the second line space, we exclude patients who have extrahepatic disease that was determined over the 9 months or so that they received their first line therapy, and had a better idea of patients with truly liver confined disease. So this is not for everybody. I would propose that this therapy could be helpful for those patients who have disease confined to the liver, unresectable disease, either due to distribution of their lesions or other factors, and patients who have a good performance status and are able to receive standard systemic second line therapy. The the other factors we're going to be studying, looking at which patients perhaps could benefit most from this and which patients did not have a benefit by the addition of yttrium-90. We're going to be evaluating all this data that we've collected to identify patients who would be best served with the addition of Y90 to their second line chemotherapy. And we're looking at things like the duration of time they were on their first line of therapy, their response to their first line of therapy, KRAS mutation, the side of the primary tumor, whether or not they had any extrahepatic lesions that were not felt to be metastatic disease, and perhaps identifying those that truly did have metastatic disease to help identify patients who may best benefit for this treatment. I'll be interested to see where the site of first progression is for patients when they progress after getting Y90 as compared to systemic chemotherapy. And I think all of this, as well as identifying the changes in quality of life, which is so important for these patients with metastatic disease when it's non-curable. I think it's important to understand that this therapy can be beneficial for patients, but we need to really identify which patients would benefit most. There is a cost associated with the addition of this therapy to their chemotherapy regimen. However, it's important to keep in mind that this is a one-time treatment, not ongoing, as many of our drugs are. And hopefully we will get a better understanding of who would best benefit from this therapy. We'd also like to thank all of the investigators who spent so much time over these years working on this study. We thank the patients who trusted us with their care and the conduct of this study, the nurses and clinical staff who were instrumental in taking care of these patients and gathering the data for us. And we thank our sponsor, Boston Scientific, who's been supportive of us throughout the time of this study.